All right, welcome everyone. In this little video, we'll talk about heart blocks, one of my favorites. So let's take a look at the different types of heart blocks we'll talk about. Heart blocks, first degree, second degree type 1, you'll also hear called Mobitz 1 or Wenckebach. You'll also hear second degree type 2, that's Mobitz 2. We're really trying to get away from using people's names in medicine to describe what's happening. It's easier to name it something that's actually a good descriptor rather than who came across it or who first reported it. And then last but not least, we'll talk about third degree heart block. All right, so let's get right into it. I want you to remember that so far when we've talked about the different areas of primary pacemaker site, we've talked about the sinus nodes, we've talked about atrial activity, we've talked about the AV junction as being the primary pacemaker, and then of course we've talked about ventricular tissue being the primary pacemaking site. So now we're going to look at something a little bit different, and we're going to say that sometimes the heart is actually working in terms of its pacemaking capability, but what's really happening is that there's a level of dysfunction either just below the AV node, so infranodal, or there's a level of dysfunction inside the AV node itself that's preventing either a sinus impulse from communicating down to the ventricles or an atrial impulse from communicating down to the ventricles. And when that happens, when there's some sort of blockage of electrical signal, either infranodal or within the node, then we're going to refer to that as heart block. All right, so that's kind of like the purpose of this whole heart block business, is to decide and to define the degree of loss of signal, if you will, from the top part of the heart down to the ventricles. So first degree heart block, we're going to say, is a very benign thing, and you're going to see it a lot. It can be medicine induced, it can be seen with advanced age, all sorts of things can happen, and really it's of no consequence to anyone. So first degree heart block is simply a PR interval that exceeds 200 milliseconds. So this is a great example of that. Let's take a look at this. You'll see that if you take this as the starting point of the P wave all the way to this point here, which is the starting of the QRS complex, I think we count out just about 5 or 6 boxes here. Let's see, 1, 2, 3, 4, 5, and change. So we're going to call this about 220 milliseconds. All right, so same thing here. All right, you'll see that it starts and stops. It's just a little over 5 boxes here. So 220 milliseconds, in fact, satisfies this requirement of over being 200. This is called first degree heart block. Now, please understand that we've gotten lazy in medicine, and we kind of name things by the degree of heart block, but that's not really accurate. The better way to do this would be to say that the heart block, level of heart block, is something that happens within a underlying rhythm. So in this case, if we look at this, there are P waves, they're upright and rounded, they precede the QRS complex, which is of normal duration, and the rate here is 300, 150, 100, 75. So in fact, this underlying rhythm is sinus rhythm, and then we'll add this modifier with first degree heart block. All right? So first degree heart block is this thing, it's almost like the premature beats. They occur on top of or within a rhythm, but they themselves are not a rhythm. So always remember to name the rhythm first, and then we'll add this heart block condition on top of it. So this is sinus rhythm with first degree heart block. All right, easy one. So the only difference between a normal sinus rhythm without first degree heart block and a normal sinus, for example, with first degree heart block is nothing more than that the PR interval is greater than 200 milliseconds. All right, so let's take a look at a little bit more of a difficult or a little bit more involved heart block. And this is second degree type 1. Second degree type 1 is usually an infranodal block, which means that it's happening just before the AV node. It's not actually a disease within the AV node. And this is kind of an important distinction to make, because usually the infranodal blocks are completely benign, and the blocks that happen within the AV node tend to require some sort of aggressive intervention, such as whether it's transcutaneous pacing or transvenous pacing in the emergency room setting or in a critical care setting. That's going to kind of be the differentiator here. All right, so let's take a look at what happens in second degree type 1 heart block. So as you'll notice, let's take a look at this green tracing on top first. As you'll notice, in fact, we do have P waves that precede each QRS complex. All right, so there's a P here for every QRS complex up until we get to this guy here. So let's take a look at what's happening. If we were to look at this underlying rhythm, at first glance, it looks like sinus rhythm. It looks like sinus rhythm because there's a P wave, it's upright, it's generally rounded before the QRS complex. The PR interval looks to be reasonable in this particular section here. The QRS duration is of normal duration, and if we look at it, the rate is 300, 150, 100, 75-ish, all right, so maybe a little bit less than 75. So really, this is sinus rhythm. But then when we start looking at it, we do notice that the R to R complexes are of same distance apart. So in fact, here we have pretty much a very regular rhythm up until this point here. So we're going to kind of focus on this for just a second. All right. So the next thing we're going to look at here that's going to allow us to include this diagnosis is if we start looking at what the PR intervals are doing, this is really going to tell us a lot about the underlying rhythm. So this is kind of a short strip to be doing this with, but it's actually a great strip because it illustrates the concept pretty clearly. So take a look at the PR interval here. If you start here and you end there and you measure this out, it's like 3.5 little boxes. Then if you start this one and end here, wow, this one's about 4.5, 5 little boxes. Do the same thing here. Whoa, we're at 6 boxes. Do the same thing here. We're at 7 or 8 little boxes. Do the same thing here. We're at 9 boxes. So essentially we've gone from 3, 5, 7, 8, 9, I don't know, almost 10 here, right around 9, so we'll put this one at 8. But what you see is that the PR interval is actually getting longer in all of these. So looking at the PR interval is really important, and looking across the rhythm is very important because an elongating PR interval is a really conclusive finding. So now let's look at what happens after this red line. So we have a P wave that shows up, yet there's no QRS complex followed. So essentially what's happened here is the heart has decided, hey, the PR interval's gotten so long, we need to reset that. So we're going to reset that area just before the AV node. So we're going to allow the SA node to fire, and then we're going to let the AV node do absolutely nothing whatsoever. And look what happens here to the PR interval. It completely resets to what it was back over here. So essentially the heart's pretty smart. It likes to be on some sort of paced sequence, and when it starts to fall out of that, it does everything it can do to try to reestablish that sequence. So PR interval has elongated to the point where now there's a sinus beat, and it never makes it down to the level of the ventricles. It's blocked from doing so as the AV node and the infranodal area is reset. And then it does reset to a normal PR interval. And if we were allowed to see the rest of this strip, this would continue to happen. All right, so second degree type 1 heart block is characterized by an irregularly irregular rhythm. Right? I'm sorry, this should say a regularly irregular rhythm, in that we're going to see some groupings of beats here. This should be regularly irregular. We're also going to see an elongating PR interval. And last but not least, we'll eventually see what appears to be a dropped QRS complex. So these are really important findings on the EKG. All right, so the trick is this. I told you, I think it was on the first day we looked at regularly irregular rhythms. I told you there are only 2 things that it can be. The first thing that it could be was an underlying rhythm with the presence of some sort of premature activity. It could be PACs, PJCs, or PVCs. So you could have sinus rhythm with PACs at every 3rd beat. And essentially what it's going to allow you to do is see that there are grouped beats. So grouped beats can only be 2 things. It can be the presence of an underlying rhythm with premature beats, or it can be second degree type 1 heart block. All right, now, what I want you to appreciate is that it's easy for us to differentiate grouped beats that are from an underlying rhythm with premature activity and second degree type 1 heart block. And here's how we do it. We look at the P to P interval. So again, let me clean up a little bit of this slide here so that you can see what's happening. But if you look at the P to P interval here, what you'll notice is that the P to P interval is extremely constant here. So if you look at this P to P interval, the P to P interval is exactly the same. Now, that's second degree type 1 heart block. So if the P to P is constant, it's second degree type 1 heart block. If the P to P interval happened to be variable, meaning that, let's say that instead of being exactly perfect with this P to P interval, here we have perfect, perfect, perfect. Let's say this next one showed up here, much shorter of a distance than this one, or this one, then this would be a PAC. Now, in this case, I won't be able to show you what a PAC looks like on this tracing because that's not what we're looking at. Perhaps I should have included one of those as part of the rhythms to differentiate here. We'll do so in class. All right, but I want you to think, when you see grouped beats, think two rhythms, either an underlying rhythm with premature activity or second degree type 1 heart block. It's second degree type 1 heart block if the PR interval elongates, if eventually you have a dropped QRS complex, and if you have grouped beats that have a constant P to P interval. All right, let's take a look at another second degree type 1 heart block also on this slide. All right, this makes life easy just to keep looking at them. So if you'll notice here, we do have grouped beats, don't we? These two guys here are the same. They're just different lead views. All right, we won't worry about the different lead views for now. But what should stand out here is that the beats here are grouped. So there are groups of 3 that are occurring here across this tracing. So that's an important finding because, again, that tells us right away that either we have an underlying rhythm with premature activity or we have second degree type 1 heart block. All right, so let's take a look to see if it's second degree type 1 heart block. So we're going to go, the ideal thing to do is always to find somewhere where it looks like there's been a dropped beat. All right, so that's a great place to start. Anywhere where you think there's been a dropped beat, this is where you would start. And by what I mean by start is right after the area where you think there was a drop beat, you take a look at the PR interval. And then you go to the next beat after that, and you do the same thing. You look at the PR interval. And then you do the same thing with the next beat. You look for the PR interval, and here you'll see again, we have this PR interval, followed by this PR interval, followed by this PR interval, and then it looks like we drop a beat. So we have a regularly irregular rhythm such that we have grouped beats. We have elongating PR intervals. This one starts out small, gets longer, and then ultimately we drop a beat that's here altogether. And this is, in fact, characteristic of second degree type 1 heart block. So we'll talk about the treatments in class, but just understand that second degree type 1 heart block, for the most part, is completely benign, and we don't really do anything for it. All right, let's take a look at some more heart block stuff. Let's take a look at something that's a little bit more sinister. We'll take a look at second degree type 2 heart block. So second degree type 2 heart block speaks about a higher level of dysfunction at the level of the AV node, the gatekeeper between the atrial stimuli and the ventricle's ability to receive that stimulus. All right, so second degree type 2 heart block is characterized by a PR interval that is constant. So this already differentiates second type 1 from second type 2 because in second degree type 1, the PR interval was variable. The PR interval in second degree type 2 is constant. The R to R interval is also constant, and I'm going to put a little asterisk next to it to indicate that sometimes it can be irregularly irregular. And this just depends on how many P waves exist between each QRS complex. All right, so PR interval for the most part is constant. No, I'm sorry, PR interval is always constant in second degree type 2. The R to R interval is almost always constant in second degree type 2. And we're going to take a look here at some examples because this makes it a little easier. Now, some people will still tell you need to look at the P to P interval, and I will tell you that's kind of silly to do because the P to P interval is always constant in heart block. So you can certainly measure that. There's nothing wrong with that. Just know that finding a P to P interval that's constant doesn't tell you very much information. All right, so let's take a look here. I just want you to look at this top rhythm for a second, and I want you to look at the P waves. And so if you want to pause the video for a second, that's great. I want you to tell me how many P waves exist between each QRS complex. All right, so think about that for a second. Pause the video for a second. Really scrutinize the EKG, and let's figure out how many P waves there are. All right, welcome back. Hopefully you were able to find all the P waves on here. So let's go to the ones that are obvious first. So there's a P wave here, and a P wave here, and a P wave here, here. I think each and every single one of you probably recognized the location of these P waves. Now, I started by saying you don't need to look at the P to P interval because it's always constant. That's a given. What you do need to keep in the back of your mind is that the P to P interval is constant, and therefore when you see grouped P to P intervals like this, you'll see that the P to P interval right here is this long, and here it's this long, and here it's this long. So how many P waves are in between each QRS complex? And the answer is 3. So let's take a look at where that third one is. If you were to map out this P wave activity, and you were to follow it out like so, and you were to follow it out again like so, and you were to follow it out again like so, you'll see that in fact these guys march out perfectly. So what's happened here? How come we can't see the P wave? Answer: the P wave is masked by the activity of the T wave. And so in fact you'll see that if you were to march these out, they march out perfectly and they line up perfectly with the T wave, and therefore we know that there are 3 P waves for every QRS complex. All right, so in second degree type 2 heart block, we must have a constant PR interval. We must have a constant R to R interval for the most part, but there's this caveat that sometimes we can have varying numbers of P waves. For example, let's say we had 3 P waves between QRS complexes. Then let's say we had 4. Then let's say we had 4. Then let's say we had 2. Then let's say we had 5. This is going to make this an irregularly irregular rhythm. This is less common than what you're going to see here with this example, and that is a constant R to R interval. So if you look at the R to R interval here, it is very constant. Right? They're the same exactly across the board here. Constant R to R, constant P to R, and more than 2 P waves for every QRS complex. This defines second degree type 2. All right, so same thing here. This was just a blown up version, a zoomed in version, just to say that if you want to measure out your P waves, you'll see that P wave activity actually falls right inside the T wave. So there's actually a little P that's in here. It looks just like this if we could isolate it, but in fact repolarization of the ventricles has taken place at exactly the same time, and therefore we end up with a T wave that completely masks the atrial depolarization activity. All right, now, excuse me, let's take a look at something that's a little bit more complicated. This is not something that's generally taught to paramedics, and so I want you to know this information, but I also want you to appreciate that on most standardized exams for paramedics, you won't see the option of 2-to-1 AV block as an answer, even if that's what the tracing is. What you'll see the correct answer will be second degree type 2. We've kind of gotten lazy, and because we've had little physician oversight along the way, not in Montgomery County, just in general in paramedic education, this has kind of slipped people's awareness. We just don't teach people about this, so people aren't aware of it. So let's take a look at how to differentiate second degree type 2 heart block from 2-to-1 AV block and what exactly 2-to-1 AV block is all about. So if we look at this EKG, at first glance, everybody's going to catch these P waves that are occurring here. All right? And in fact, if you measure out the P to P intervals, you'll notice that the P to P interval is exactly the same, so nothing's hidden anywhere. And if you were to look at the R to R interval, you would also note that it is exactly the same, it is constant. So therefore, a constant PR interval and a constant R to R interval and more P's than QRS's should define second degree type 2 heart block. Here's the problem. The problem is when there are 2 and exactly 2 P waves for every QRS, we have no idea if this is second degree type 1 or second degree type 2. And here's why. Remember second degree type 1 heart block. We said was a PR interval that elongated to the point where it dropped a QRS complex. So my challenge to you is to think abstractly here and to say to yourselves, is it possible if we start at PR interval number 1, that in fact where this second P wave occurs, this actually is the second P to R interval, and in this area a dropped QRS has occurred. Then it has normalized. This is again equal to number 1. Here we have the second P to R interval where the QRS complex was dropped. Then we have the next PR interval, which is normalized, equal to 1. Here we have the second one where we dropped a QRS complex. So that's possible. The possibility exists that at every other P wave we had a dropped QRS complex. And so this could be second degree type 1. Now, conversely, could this be second degree type 2? And the answer is, well, of course it could be, because it's got a constant P to R, it's got a constant R to R, and it has more P's than QRS complexes. And in the previous screen, we said when that occurs, you have second degree type 2 heart block. All right, so since we have no idea what this is, meaning that it is not possible for us to differentiate second type 1 from second type 2, if there are 2 and exactly 2 P waves for every QRS complex, instead of defining a specific term, second degree type 1, or the specific diagnosis of second degree type 2, instead what we do is we now label it objectively by what we see. So we'll say that there are 2 P waves for every QRS complex, and as a result, that means that there's AV block. So we call this a 2-to-1 AV block. 2 P waves for every QRS complex, and there's some level of AV block. That way we don't pin ourselves down to a specific second degree type 1 or second degree type 2 diagnosis. Instead, what we'll do is we'll just generically call it 2-to-1 AV block. All right, so this is a really important distinction because this tells us that we have very little knowledge about what this underlying rhythm actually is. So we're just going to generically call it 2-to-1 AV block. We'll do more of this in class. What I do want you to walk away with is that if you were to see this on any sort of standardized or EMS exam, you would call this second degree type 2 because of the constant PR interval, because of the constant R to R interval, and because of the multiple P's per QRS complex. But in the real world, and you'll have to teach your peers this, in the real world, if there are 2 and exactly 2 P waves per QRS and a constant P to R interval and a constant R to R interval, we have to call this 2-to-1 AV block. All right, this must be called 2-to-1 AV block. All right, let's talk about the next guy here. Next guy is going to be the last guy. So the last guy is, you quickly look at the EKG and you scan it, and you'll notice that, in fact, we have P waves that occur here. Now, I'm just going to point out the P waves that are obvious, super obvious. And then we're going to go back for a second, and we're going to say, hey, this P to P interval is cool, but then look, something happens here. And then something happens here. We get another P wave. So what's happened here? This is actually a P buried inside the T wave. Same concept here. Go here. Go here, there is a P wave that's buried, and you'll start to see that actually the T waves look different. And the reason they look different is because they've either been masked or mimicked by the P wave. So let's take a look here at what I mean by that. I want you to see that when we look across this tracing, that this P wave, this T wave looks different than this T wave, looks different than this one, looks different than this one, looks very different than this one because the P is right on top smack dab of that one. So these guys kind of all look different, all right? Look at the P that's right there buried inside the T wave. So their amplitudes and their shapes are all a little bit different, and that proves to us that there's actually a P wave that's buried inside there. So third degree heart block is kind of an easy heart block to interpret, and here's why. Remember that we want to look at the PR interval. All right, and the PR interval in this case, if we look at it, look at this PR interval, look at this PR interval, look at this PR interval, PR, PR. If you look at these PR intervals, there is absolutely no relationship between them. So these guys are variable. PR is variable. Yet when we look at the R to R interval, these guys are all exactly the same. So the R to R is constant. So constant R to R interval with variable PR intervals and more P's than QRS complexes. This defines third degree or complete heart block. So this tells us that none of these P waves none of these P waves are actually producing the QRS complex that follows it. Now, I also want you to appreciate an additional piece here. When we talked about the idioventricular rhythms, we also said that it could be called a ventricular escape rhythm. And at that time, I mentioned to you that the difference between a ventricular escape and an idioventricular rhythm was not in their appearance. They're both exactly the same in appearance, but it was how this ventricular escape got there. So in this case, what we have is we have a 100% blockage of the AV node. So there is absolutely no atrial or sinus node activity that's making it down to the level of the ventricles. So you'll see that we actually have sinus rhythm here. How do we have sinus rhythm? Because we have P waves, they're upright, they're rounded, and they're occurring at a rate of 300, 150, 100. It's actually, you could even call this sinus tach. We can call it sinus tach or sinus rhythm. So we could call this sinus rhythm with third-degree heart block so far. All right, now let's talk about the three components that are taking place here. So there's an atrial component, there's an AV nodal component, and then there's a ventricular component. So we already said that the atrial component is that there's sinus rhythm. There's sinus rhythm because there are P waves and they're occurring at around 90 or 100 beats per minute. We also discussed and defined the level of AV nodal activity as complete dysfunction, 100% blockage. Here we said third-degree heart block. What we have yet to do is describe what the ventricles are doing in response to all of this. So the atria are doing their thing, meaning that the sinus node is depolarizing 90 times per minute, and it's just carrying on its business in a very regular fashion. The AV node, for whatever reason, is unable to communicate any of those impulses down to the level of the ventricles, and we have defined that inability to communicate as a complete heart block or third-degree heart block based on the presence of a variable PR interval and a constant R to R interval. So now let's look at what the ventricles are doing. What happens to ventricular tissue if the rate coming either from the atrial tissue above or the rate coming through the AV node drops below 40 per minute? And the answer is, well, the ventricles will now assume the primary pacemaker site. So if the sinus node fails, or if the AV node fails to transmit the sinus node's impulses, and if the underlying rate coming from above that is allowed to reach the ventricles falls below the inherent firing rate of the ventricular tissue, then the ventricles assume the primary pacemaking capability, and this is called a ventricular escape rhythm. So ventricular escape rhythm is a rhythm that occurs, for example, when we have complete heart block, one of the things that can occur. So ventricular escape rhythm can come about when there's absolutely no level of coordination between the sinus node and the ventricles because the AV node is completely blocking those signals. Now, how do we know this is ventricular escape rhythm? Well, forget the level of heart block for a second and forget the P waves that are there. If you were to eliminate all these P waves from the tracing, just get rid of them, and just interpret the ventricular component of this, we would look and say, hey, there are no P waves, the rate is less than 40, the rhythm is very regular, the QRS is greater than 120 milliseconds, and there's no measurable PR interval. These characteristics define idioventricular rhythm. They define idioventricular rhythm. It's wide, it's slow, and there are no P waves. It's idioventricular rhythm. In addition to that, look at the discordance that exists between the QRS and the T waves. They're pointing in opposite directions. So QRS and T wave discordance is another great way, discordance is another great way to look at this tracing and say, hey, we actually have a level of dysfunction here, and it is a ventricular rhythm that's causing this. All right, so we're always going to look at that. Now, since we have complete heart block, meaning that the AV node is the one that's actually causing all the problems here, we're going to allow all those P waves into our decision-making process, and in doing so, we're going to say, aha, since the the AV node is not allowing any of these impulses, the sinus impulses, to get to the ventricles, that means that the rate received by the ventricular tissue has fallen to a rate below the inherent firing rate of the ventricular tissue, and as a result, the ventricles have escaped to become the primary pacemaker. So instead of calling this idioventricular, we call it ventricular escape rhythm. All right, so we could have, it's just as likely that we could have a junctional escape rhythm. So you can have sinus rhythm with third-degree heart block and a junctional escape rhythm. In this case, it is a ventricular escape rhythm. All right, so if we wanted to look at the entire name here, this is a great way to do it in your head as you're learning this. You would call this a sinus rhythm with third-degree heart block and a ventricular escape rhythm, because that actually describes all three components, the atrial component, the AV nodal component, and the ventricular component of this rhythm. It also very clearly describes how we'll approach our treatment now for this, which we'll talk about in a separate video. All right, so let's summarize all of the things we just talked about. So when you look at an EKG, if you see more P waves, more Ps than Qs, meaning more P waves than QRS complexes, if you see more P waves than QRS complexes, you should ask yourselves two questions. And the two questions are, what is the PR interval doing? And what is the R to R interval doing? And then you need to kind of commit this to your head, all right, to memory. So let's take a look at these different guys here, and let's talk about the level of dysfunction that's taking place here. So you can draw yourself this little chart, and this little chart's always going to give you the answer. All right, so let's put second-degree type 1 heart block, second-degree type 2 heart block, third-degree heart block. All right, now this chart you have to commit to memory. So the PR interval in second-degree type 1 heart block, I'm going to write it as variable. You can also think of it as elongating. I like to think of it as variable instead of elongating for one reason and one reason only. If you look at third-degree heart block, what is happening to the PR interval if your brain and your eyes start here? What happens to the PR interval if you look at this? And the answer is this PR interval has also elongated, yet this is not second-degree type 1 heart block. This is complete heart block because of other rules. So it is sometimes better to think about it as being variable as opposed to simply elongating. Even though it is elongating, sometimes I like to think about it as variable because this is going to allow you to see that we have to differentiate second-degree type 1 from third-degree. In the end, it doesn't really matter. It's just to say that it is not constant. The R to R interval in second-degree type 1 heart block is variable. And again, another way to look at this is that you have a dropped QRS. Another way yet to look at this is to say that you have grouped beats. Grouped beats. Really important. This really tells us a lot of information when we can recognize this. All right, so let's go to second-degree type 2. Second-degree type 2, PR interval is constant, and the R to R interval is constant. Just remember that I'm going to put this little asterisk and say sometimes it can be irregularly irregular if there is a level of variable conduction. And the example that we gave of that is that if there are varying numbers of P waves that separate QRS complexes, then second-degree type 2 can be irregularly irregular. All right, last but not least, third-degree heart block, PR interval is always variable. The R to R interval is always constant. So, if you look at an EKG and there are more P waves than QRS complexes, you should ask yourself two questions and only two questions. What's the PR interval doing? What's the R to R interval doing? If the PR interval is variable, think second-degree type 1 and third-degree. If the R to R interval is constant, think third-degree and second-degree type 2. Then you look at the other component to differentiate each from the other. So if you find variable PR intervals, the way you differentiate second-degree type 1 and third-degree heart block is by looking at the R to R. In second type 1, it'll also be variable. In third degree, it will be constant. So let's say you notice that there's more P waves than QRS complexes, but the R to R intervals are constant. The way you differentiate second degree type 2 heart block from third degree heart block is by looking at the PR interval. If the PR interval is constant, we have second type 2. If the PR interval is variable, we have third degree heart block. All right, so stay tuned. We'll talk about the treatments in the next video, and I look forward to seeing you in class so we can start practicing these guys.